In the lower quadrant scan, the following points are of particular interest to the therapist. Naturally, the most important aspects of the history are those that suggest serious pathology. The following are indicators of serious disease. Constant, unrelenting pain that worsens at night suggests chemical pain that may be due either to hyperacute inflammation, infection, or neoplastic disease. Expanding pain as opposed to static or shifting pain. Expanding pain is pain that starts in one area and spreads without relief to others. This would suggest something growing in size and could indicate a neoplasm or infection. Multisegmental paresthesia or hemiparesthesia is suggestive of neurological involvement of the spinal cord or higher. Pain across the upper two lumbar levels, the so-called forbidden area pain, may be caused by high lumbar metastases, as disc and joint lesions at these levels are unusual. For the same reason, lumbar 1 or 2 palsies should suggest neoplastic compression, as disc herniations here are rare. Severe bilateral sciatica may indicate cauda equina compression, as would saddle paresthesia or bladder or bowel dysfunction that is associated with back or leg pain. Such dysfunctions may take the form of retention that is characterized by strong urges to urinate but subsequent low volume, or by incontinence. These and/or genital dysfunctional changes are extremely serious signs demanding that the patient be referred back to the physician. On the less serious side, the history will begin to afford a picture of a type of lesion that the therapist is dealing with. Referred pain comes in two varieties, somatic and radicular. Radicular pain originates from inflamed or previously damaged nerve tissue and is characteristically sharp and lancinating, coming on when the tissue is stressed and going off when the stress is relieved. Somatic pain comes from non-neurological structures, including the dura mater, and is duller and generally comes on and goes off more gradually. As a general rule, disc herniations are more adversely affected by flexion activities and postures, with these patients disliking sitting and bending, but finding relief in extension positions and activities such as standing and walking. Zygapophyseal joint dysfunctional and stenotic patients tolerate flexion better than extension, and the stenotic pain tends to be gentler and less disabling. Intermittent claudication pain is sharp ischemic pain brought on by a set amount of exertion, such as walking a certain distance, and relieved, at least in its early stages, by discontinuation of that exertion in any posture adopted.